first part of my talk will focus on sources of low back pain, history and physical exam techniques, evidence-based treatments, and imaging guidelines. And the second part will focus on findings of recent research with our Hohenstein Spine Center patients, specifically my dissertation research. It's important to remember that low back pain is not a homogeneous clinical condition. It is a symptom, and it affects most of us at some point in our lives. And most of these episodes improve dramatically within a month without any particular treatment. People with low back pain are likely to have recurrent episodes, and it's a big problem. Conditions involving the low back comprise the 5th most frequent reason for hospitalization, the 3rd most common reason for any kind of surgery, and the 2nd most common reason for work absence. The estimated cost, and various methods have been used to estimate this, and its direct and indirect costs of low back pain vary between $50 and $625 billion a year in the United States. We know from research that low back pain and leg pain together can result in reduced physical function. And we know very specifically from research that there are physiological, situational, and psychological factors that patients bring to the mix that actually affect their outcomes from treatment. This is a list of potential pain generators in the lumbar spine. There are many, and the problem is that most of these refer pain in similar patterns. And this slide is a compilation of different composite pain diagrams from different interventional studies. The first 2 sets are interventional studies for patients with known L5 and S1 radiculopathy, respectively. The 3rd set is from patients with sacroiliac joint-mediated pain. The 4th set is from facet-mediated pain, and the last is from discogenic pain that was generated by IDET, or intradiscal electrothermal therapy. So it's very difficult to differentiate the pain generator simply by the distribution of the pain alone. It's really important to put disc degeneration into proper perspective. It's a universal human condition, so that by the time we're 30, 40% of us will have disc degeneration. By the time we're 50, it's almost all of us. And it's referred to as a disease, but it only simply refers to the state of the disc. It's part of the aging process. As our discs lose the proteoglycans, those are the molecules that hang on to water, the discs become thinner and more fibrotic, less organized. We know that the posterior 1/3 of the annulus is innervated, and we know that increased vascularization and nerve ingrowth of the posterior annulus can contribute to pain. And high intensity zones or tears in the posterior annulus can contribute to leakage of proteoglycans, and it can create an environment that's conducive for ingrowth of nerves and vascular structures, which does enhance pain. The natural history of disc herniation is that 80 to 85% of the time, disc herniations resorb, and so do the symptoms resolve. There's not a direct relationship between resolution or reduction in size of the disc herniation and the patient's resolution of symptoms. We can still see patients with disc herniations whose symptoms have completely resolved. And the clinical outcome doesn't depend on the size of the disc degeneration, the size of the disc herniation, or the degree of disc degeneration. There have been studies that have looked at serial MRI findings in order to predict patients who will develop symptoms over time. And even with 7-year follow-up in serial MRI studies, MRI findings cannot be used to predict which patients are going to go on to exhibit symptoms. So MRI has high specificity and low sensitivity in these patients. There's a poor correlation between imaging findings and the clinical presentation or the clinical course. And Mouse said that only when an imaging finding is concordant with a patient's pain pattern or neurologic deficit can causation be considered. So these are actual pain diagrams from patients who presented to the Spine Center. And this can be a difficult population. So where do we begin? Up to 85% of mechanical low back pain can't be traced to a single pain generator. And that's a challenge because patients and providers want to identify the source of pain. So since there's many sources of pain, it seems simplistic, but careful history and physical is key. You have to be able to place the patient's pain into 3 categories. First, nonspecific mechanical low back pain. Second, mechanical low back pain with associated neurologic involvement. And third, back pain of a serious underlying cause. Your pain diagram provides cues about whether the pain is anatomic, whether it correlates to known pain generators, and it's important to differentiate pain of other origin, hip, vascular claudication, or shoulder in the case of cervical spine pain, from lumbar pain, from spine-related pain. So since these nociceptors are many and varied, some of them have different personalities on mechanical testing, and we won't go into that specifically, but it can't be overstated that a very good mechanical evaluation of the lumbar spine needs to be employed. You have to also thoroughly examine the hips, the sacroiliac joints, and the patient's vascular status. And I find that accurate identification of the pain generator is enhanced with combined physical therapy mechanical testing, which provides very helpful support for what your thoughts are clinically on patients. These are the evidence-based treatment strategies in these patients. McKenzie-credentialed spine therapists obtain better outcomes with regard to pain reduction and physical function than back school or physical therapists who are generically prepared. In some cases, McKenzie-credentialed spine therapists are accurately able to predict early on who's going to be able to respond to conservative therapy and who the non-responders will be who need to go more quickly to surgery. With regard to steroid injections, Weinstein and Herring looked at many randomized controlled trials, and they conducted 3 systematic reviews. And most of these had methodological flaws. They had small sample size or non-comparable control groups. And before 2000, there was a lack of fluoroscopic guidance for injections. But these were their recommendations based on the systematic reviews. Epidural steroid injections can be endorsed for lumbar radiculopathy pain from a disc herniation. There's no good data in the literature to support injections for nonspecific low back pain. There's no role for a continued series of injections if the first isn't helpful. Lumbar epidural steroid injections can provide a window of opportunity for other treatments to improve the patient's status. And unfortunately, relatively few providers are responsible for a disproportionately high number of procedures. What they found was that the highest 10% of the providers performed 9 times more injections than the lowest 10% of providers in interventional pain treatments. There is evidence that the use of bone scan with SPECT-CT reduces the overall number of facet joints injected and is associated with better post-procedure pain scores. A recent Cochrane review for the use of TENS in chronic low back pain revealed that there's just not sufficient evidence for its use. And 2 recent Cochrane reviews looking at chiropractic treatment for both acute and low back pain revealed that there is no evidence to suggest that that's better than sham. And it's interesting that those studies were co-authored by a chiropractor. So these are the recommendations for advanced imaging that are evidence-based guidelines based on multiple systematic reviews. And these are from the American College of Physicians and the American Pain Society. There's no routine imaging that is recommended for nonspecific low back pain. Imaging can be recommended for severe or progressive neurologic deficit or suspected serious underlying neurologic cause. Imaging for suspected radiculopathy or stenosis is only indicated if those patients are candidates for epidural steroid injections or surgery, invasive treatments. And it's important to recall the weak correlation between MRI findings and the clinical presentation. The last half of the talk will be focused on the dissertation study with our patients at the Spine Center, which will reveal important information about what we should do to treat these patients. So the dissertation study aims were there, but the first was to determine the contribution of physiological, situational, and psychological characteristics that patients bring with them to the table, to their symptoms and their physical function. And can we develop a predictive model for who's not going to do well based on those factors? And can we explore the impact of genotype on some of these outcomes? And from the literature, this is what we specifically know about physiological factors. A BMI over 30 is a risk factor for low back pain, even when adjusted for smoking, age, work status, education, and physical activity. Those who are overweight or obese are more likely to have disc degeneration at an earlier age, more severe disc degeneration, and it's worse if you're overweight at an earlier age. Spine degeneration increases with age. There are differences in pain experiences between sexes. Females experienced greater pain in spinal stenosis than males did. Smokers have a higher incidence of low back pain. Current smokers have the highest incidence, with previous smokers in the middle and never smokers with the lowest incidence of low back pain. And it's interesting, a study identified that smokers receiving treatment for low back pain had higher pain visual analog scores than non-smokers, but those who quit during treatment had greater improvement in their Oswestry disability scores than those who didn't quit. So there is a difference if you quit. Oswestry Disability Index is a lumbar-specific function tool. On situational characteristics, we know that work conveys a protective benefit for physical function. Employment preoperatively is associated with better physical function and less pain post-op after spine surgery. And of all the patient characteristics studied, working prior to treatment for low back pain was the variable most strongly associated with improved Oswestry scores after treatment. We know that workers' compensation is associated with worse functional status after surgery and non-surgical treatment for low back pain, and underfunded insurance plans and lack of insurance were associated with worse health outcomes in general. We know that depression is associated with higher pain estimations and worse physical function. In fact, depression can contribute to development of chronic low back pain, and it's negatively correlated with return to work after surgery for disc herniation. And depression is a better predictor of future pain episodes than MRI findings. That is profound. Back and leg pain together is associated with worse physical function than either one of those symptoms alone. So this is some of the study results, and this was a cross-sectional observational design. 163 randomly selected patients from a database in our spine center. For all of you future researchers, there's 1,300 patients in our database of patients who presented to the spine center from 2009 to 2012 with complete Oswestry Disability Index information and SF-36 outcome scores. Patient characteristics that we listed earlier were obtained from the medical record, and a random subset of 28 patients provided saliva samples for genotyping. I used multivariate statistical analyses, and the genotyping was done at Michigan State University Core Genomics Lab. The outcome measures, as I said, were the Oswestry Disability Index and the physical function subscale from the SF-36. The physiological characteristics studied included BMI, smoking status, age, and sex. The situational characteristics studied included insurance type, work status, and workers' compensation. And the psychological characteristics studied was depression. 42% of the population was obese or overweight compared to the state of Michigan average of 31.1%. In fact, 30% of the sample had a BMI of 25 to 29.9. Another 30% had a BMI of 30 to 39.9. And 12% of the population were class 3 obese with a BMI of 40 or higher. One patient had a BMI of 71. 28% of our study population were smokers, compared to the American average rate of 18% for adults. The mean pain visual analog scale was 6.83, and that borders on severe. Scores from 7 to 10 are considered to be severe. 31% of the population was depressed, and compare that to Dr. Tanner's presentation where 2 to 20% of the normal population is depressed. And I was surprised at the lack of workers' compensation and auto patients that were represented in this sample. So the Oswestry Disability Index mean scores for these patients were above 50. And for the Oswestry, higher scores reflect worse physical function, and scores between 40 and 60 represent severe disability. And what I've placed on there also is some of the other known scores for populations with sciatica and spinal mets. Compare that to this population. They perceive themselves to be more disabled than patients with spinal mets. Likewise, for the SF-36, these are opposite. So lower scores represent worse function. So the sample mean was in the neighborhood of 32, but compare that to a healthy population, a population with sciatica, and a population in the 25th percentile for cancer. So this was an incredibly disabled population. So results for AIM-1, and that was the contribution of patient characteristics to symptoms and physical function. Smoking, having Medicaid or no insurance were associated with higher pain visual analog scores. So nothing related to their diagnosis, and that represents 30% or 13% of the variance. Higher BMI and smoking were associated with worse ODI scores, while commercial and Medicare insurance were associated with better ODI scores, and that represented 18% of the variance. And for the SF-36 physical function scores, higher BMI, smoking, older age, and Medicaid were all associated with worse scores, and that explained about 18% of the variance. Results for AIM-2, and that was to try to develop a predictive model for physical function using patient characteristics and symptoms. Higher BMI, smoking, higher pain visual analog score, and extremity numbness were all associated with worse ODI scores. And fairly similar, and that explained 35% of the variance, and in social research, that's kind of a high number. For the SF-36 physical function scores, higher BMI, older age, and higher pain visual analog scores were all associated with worse physical function scores, explaining 26% of the variance. Some of the additional results, the study population mean mental health subscale score was 44.73, and that fell between a normal population and a depressed population here. The mental health subscale scores were significantly statistically related to the diagnosis of depression. And the presence of back and leg pain together was associated with worse physical function scores on the ODI, so that was consistent with the previous literature. The genotypes that were studied were different structural genes, collagen 9A2, collagen 9A3, aggregan and vitamin D receptor genes. And the two pain-related genes that were studied were opioid mu receptor genes, as well as the catechol O-methyltransferase. So none of these genotypes in this small study sample of 28 patients was significantly associated with symptoms, but the opioid mu receptor gene was associated with physical function scores on the ODI. So what does this mean for improving care? So our standard approach just focused on finding where the pain is coming from. It's probably not going to be sufficient anymore. There are very real physiological, situational, and psychological factors that influence the outcome for back pain treatment, and we see that in that study and in numerous previous studies. We need to include interventions targeted at weight loss and smoking cessation, and we need to advocate for coverage for evidence-based treatments that reduce pain, such as some of the injections and physical therapy. So we need to change our basic approach to care of patients with low back pain. Questions?
So Teri, if we're going to make a referral, do we refer, because to me it's like clearly straight to the surgeon is not the right choice anymore. How do we refer to, I mean, do we refer to you? Do we just refer to your clinic in general? I mean, how do we know who to refer you to get the right thing?
You can refer patients to the spine clinic, but I've been told by people that's not in the drop-down list. Is that true?
True.
Okay. Maybe that needs to be changed. You can refer directly to me.
Which I've done, but there's kind of a long wait list for you now.
We are working on that actively, Jane. Thanks for that.
Teri, thank you so much. What has been your experience with the interventions for smoking cessation in these patients? What's the reaction that you get? What's the level of engagement that you see that patients that will actively do that to improve their symptoms?
To be honest, we've just started that discussion as all of us in clinicians in the Spine Center, and we've obtained all of the available smoking cessation materials from St. Mary's, and I think we're going to tackle that in a more organized fashion going forward. I think this study was quite revealing in that some of the other factors aside from MRI findings play a big role. Thank you.